of the adult population, with the highest prevalence reported among middle-aged men. The condition is characterized by repetitive episodes of complete or partial collapse of the upper airway, resulting in complete cessation or reduction of the airway and oxygen desaturation. There are a host of sleep disorders, and the numbers are increasing as the time goes on. And many of them are mainly central disorders. And obstructive sleep apnea syndrome is one of the disorders which is common among the sleep disorders in general. As I said, it's because of an obstruction of the upper airway. The obstruction can be in the nose. It can be in a hypertrophied inferior turbinate or a deviated nasal septum. It can be in the nasopharynx with a hypertrophied adenoid or a redundant uvula that is pressing against or falling over to the posterior pharyngeal wall. It can be a hypertrophied tonsil which is obstructing the oropharyngeal airway, or a hypertrophied bulky base of the tongue which is falling back and obstructing the airway, or it can be a floppy epiglottis which is occluding the laryngeal airway. So anywhere between the anterior nasal opening and the laryngeal inlet, if there is an obstruction, it can result in obstructive sleep apnea. So coming to the clinical evaluation, it's very important because you will all experience that very few patients come to you saying that they are having obstructive sleep apnea or they are having snoring. And if you ask them often, if you are snoring, they will deny that because the patient is very often not aware of his own snoring. And you have to include the family members or the bed partners when you are taking a history. They can give you a history of disturbed sleep, and they have daytime somnolence, that they feel tired, like even after one full night's sleep, or even that sleep need not be a restful sleep, and maybe a disturbed sleep. So they don't feel fresh in the morning, and they feel tired, and if they sit somewhere, they fall asleep within a few minutes, and they want to sleep more than the usual. So this can be evaluated by the Epworth Sleepiness Score, which I'll come to later. Then the other histories can be apneic episodes. What is an apneic episode? When the patient sleeps, he's snoring, and usually it is the family member that will give you this history. Patient sleeps, he's snoring, and the snoring, the crescendo goes up, and then he stops snoring, and he stops breathing. Then after a pause, he starts breathing again like that with a choking sensation. And sometimes the patient is aware of this, sometimes the patient is not aware of this. These are called witnessed apneic episodes. Somebody has to witness that. Then only we can say that this is happening for the patient. Then there can be headache, morning headaches especially, or it can be very bad migrainous headaches. Sometimes they have vague complaints like memory loss. Then depression also can result from obstructive sleep apnea at times. When you take a history, you have to be very, very meticulous in taking the habits of the patient, like smoking, alcohol, sedatives, because all these habits can aggravate an already existing obstructive sleep apnea. Then you have to think about comorbidities that these patients can very often have, like hypertension, diabetes mellitus, and obesity, coronary heart disease, and metabolic syndrome, and hypothyroidism. All these things you have to keep in your mind while you are taking the history. So actually, when you take the history, it is the history that leads you to the diagnosis. And because, as I said previously, the patients don't complain of sleep apnea when they come to you. Epworth Sleepiness Scale, as I said, these are 8 common situations that you everyday face. And when you are going through these situations, whether you feel sleepy or not, if you're like sitting and reading, watching television, and you are traveling in a car, like whether you would never dose, you have a slight chance of dosing, you have moderate chance of dosing, or a high chance of dosing. So according to that, you score them from 0 to 3. And if your score is above 10 or 11, it is significant. Again, coming back to the clinical evaluation, after the history, the most important thing is the examination, the physical examination. The BMI of the patient is to be taken in every case. As you know, in the Indian adult male, the BMI should not be more than 25 kg per meter square. The neck circumference, again, in the Indian adult male should be less than 38 centimeter. And this should be followed by an ENT examination and a radiological evaluation. What all do you do in the ENT examination? First of all, ask the patient to open the mouth and you see the tongue. See the tongue in this patient. It's a large tongue. And you can see the indentations of the teeth on the side. That just shows that it's a too large a tongue for this mouth. So it could be a sign of an macroglossia. Then you look at the tonsil. It's almost in the middle of, like, effectively obstructing the airway. And then you look at the palate. You look at the palate. See, the tonsil, although the tonsil is only of grade 1 or grade 1, he still has a very narrow airway because the lateral pharyngeal walls are collapsing. This is the anterior pillar, this is the posterior pillar. They are in the paramedian position, effectively reducing the size of the oropharyngeal airway. Then you have to look at anatomical factors. When your patient opens the mouth, see how much he can open the mouth. He should have a good opening of the mouth. If you are planning, if you have any plans of doing any surgical procedure, especially any oropharyngeal procedure, patient should have a good mouth opening. Then look at the oropharynx and the tongue position. Tongue position, you all must have heard about the Malamute types. This is with the tongue put outside, tongue protruded. You can see the whole of the oropharynx, the posterior pharyngeal wall, the tonsils, the soft palate, the whole uvula. But that is grade 1, that is normal. Grade 2, you can see the upper part of the tonsils, but the end of the uvula cannot be visualized. And grade 3, you can't see the uvula at all, you can't see the tonsil at all, but you can still see some of the soft palate and the base of the uvula. And grade 4, it is only the hard palate that can be seen. And again, treatment position is again the same, very similar to this. Only thing, in treatment position, the tongue is inside the mouth, and the Malampati, the tongue is outside the mouth. Now coming to the investigations. What are the investigations that we can do in an obstructive sleep apnea? Polysomnography is the gold standard investigation. Then nasopharyngoscopy with Muller's maneuver. That is a fiber optic nasopharyngoscopy. Muller's maneuver, what is Muller's maneuver? That is, you are trying to breathe against a closed nose. Essentially, that is Muller's maneuver. And radiology, you can do a lateral cephalometry, or otherwise what we call an X-ray soft tissue neck lateral view. A CT will be of help. A dynamic MRI, an MRI or a dynamic MRI will be of even more help. Then comes the drug-induced sleep endoscopy. Then we have pharyngeal manometry techniques. Then acoustic analysis of snoring sounds. Out of all this, the most popular and the most important ones are the polysomnography and the drug-induced sleep endoscopy. Polysomnography is a multiple simultaneous recording of several physiological parameters that happens during sleep. Helps in differentiating between sleep disorders, like between a central or the obstructive type of sleep disorder or a disorder of any other cause. It can be of several types. Type 1 is the most reliable one and the best one, of course. Type 1 is done in a hospital setting, which where a technician is attending to the patient, and it is an overnight evaluation. For more than 4 to 6 hours, it will be done. But you can still have the home sleep study also, which is also good in terms of obstructive sleep apnea evaluation. So this figure demonstrates a standard multi-channel all-night polysomnogram. And in sleep polysomnogram, or PSG as we call it, the important things are, we have to identification of the sleep stages. Then you have to there is analysis of the patterns of respiration and analysis of movement patterns. These are the 3 factors, 3 points that you have to consider in a PSG. So the upper ones that decide the sleep stage. This is the electrooculogram. That is the right electrooculogram, the left electrooculogram, and these are all EEG recordings. And looking at the pattern of the waves. You can, the slow or the fast ones, we can decide which stage of sleep you are in. In the early stages, it is the theta and the delta, but as you go, the sleep deepens, you be going to alpha and beta. Then the chin movements, muscular movement of the chin. So that is depicted here. These represent your sleep stage. Then you have the ECG here. The snoring is recorded. And then this is the airflow. These are the ones which will decide whether your obstructive pattern will be decided by these parameters. So this is the airflow, this is the thoracic movement, and this is the abdominal movements. This is the SpO2, or the arterial oxygen saturation, and this is the heart rate. You can also have a leg movement lead for leg movements also. So looking at all these, you will be able to decide which type of sleep disorder you have, looking at the abnormalities in this pattern. Now we have to get familiar with few terms if you are analyzing a report of the sleep study. Apnea. What is an apnea? It's a drop in the airflow by more than 90% from the baseline, and it should last for more than 10 seconds. This thermal sensor exertion means that is the one which decides, which will determine the airflow. So if there is drop in more than 90% and lasts for more than 10 seconds, it's an apnea. But if the drop is only 30%, but still it lasts for more than 10 seconds, and if it is associated with a 3% oxygen desaturation, or is associated with an arousal, it becomes a hypopnea. In obstructive sleep apnea, is defined as an absence of airflow despite persistent ventilatory effects. So if you look at these two are airflow. And this is the muscular activity, and this is SpO2. So there is no airflow at all, despite lot of muscular activity happening here. Here you can see even the spikes are going up. So there is more activity happening to improve the airflow, but the airflow is not there, the saturation is falling. That is an obstructive apnea pattern. Central apnea, in contrast, this is a central apnea pattern. In contrast, is the absence of airflow due to lack of ventilatory effort. There is no ventilatory effort. See, there is no effort at all. So there is no flow, and there is oxygen saturation is falling. It's very simple to understand. So that is a central apnea. When it's a mixed pattern, it becomes a mixed apnea. You can see that there is no flow here, but as you come here there is no activity initially like the central one, but slowly the activity, muscle activity is picking up. So it's a mixed pattern. If you look at the obstructive event, we are more concerned about the obstructive event. So we'll look at it again. So this is inhale, exhale, and the patient is breathing. There is an obstruction. airway because of obstruction. Anywhere along the upper airway, there is an obstruction. So the effort gradually the flow gradually decreases. And because of that, there is an increased activity and there is paradoxical movement of the thorax and the abdominal muscles because it is working against a closed airway. And the SpO2 falls. When the SpO2 falls below a certain level, the patient wakes up and the airway opens and the paradox ends and the event is over. So that is a typical apneic event. So severity of the polysomnography report is measured by certain parameters like the apnea-hypopnea index. 0 to 5 is considered as normal. That is 0 to 5 events per hour of sleep. 5 to 15 is mild, 15 to 30 is moderate, more than 30 is severe. The other one which we commonly see is the respiratory disturbance index, which includes other episodes that happen, events which happen during sleep, which does not measure up to apnea or hypopnea, but there is a disturbance of sleep. Then the lowest level of oxygen saturation is also to be taken into account. As you all know, anything below SpO2 below 90% is considered abnormal. So if it falls below that, we have to see to that. And there is the oxygen desaturation index. What is that? It's a measure of insufficient blood oxygen during sleep. ODI, it's called otherwise. ODI is the number of times per hour of sleep that your blood oxygen level drops by a certain degree from the baseline, for example, from 90. Although there is no universally accepted normal level for this, we can take it, we can consider if it is less than 5, we can consider it as normal. Now the radiological investigations are, this is an X-ray of the lateral view of the skull. You can see this is the posterior nasal spine, this is the soft palate, this is the midpoint of the mandible towards the posterior pharyngeal wall. This is the lower border of the mandible. This is a line dropped from this midpoint to the hyoid. So what we are trying to measure or trying to see is the posterior airway space. That is between this, the nasal plane and the mandibular plane. This airway, that is the most important for us. If there is an obstruction, this is the most common site of obstruction in OSA. If you look at an MRI, it will be clearer. See, this is again the soft palate. You see the length of the soft palate and the thickness of the soft palate. And this is the posterior nasal spine. This is the posterior airway space behind the palate. And this is the mandibular posterior airway space between the epiglottis and the posterior pharyngeal wall. So in effect, this is the space from the nasal plane to the mandibular plane. The posterior airway space between these two is to be examined thoroughly on a radiological evaluation. Another thing, we can do an X-ray soft tissue neck lateral view, which we commonly do for tonsils and adenoids. You can see this, then the adenoid is obstructing the airway, the tonsil is also obstructing the airway, and the soft palate is hooked between the two. This is called the typical hooked soft palate appearance. Computed tomography can evaluate it much better and gives you a much clearer view. You see that in the axial plane, the side-to-side measurement is much more in a normal patient than the anteroposterior measurement. But in a pathological state, the anteroposterior measurement is much more than the side-to-side measurement. This is an OSA patient, obstructed airway patient. This is a normal. And again, if you see this is MRI You can see that there is the micrognathia, and it is pushing the tongue against the soft palate, against the hard palate, and the space is very narrow. And this is pushing the palate behind, and the airway space is narrowed. Here again, you can see that the palate is bulky, and the tongue is also bulky, and the posterior airway space is very much narrowed. This is a reconstructed view of from MRI, and this is the awake stage. This is the retropalatal space, and this is the retroglossal region. This is a lateral view. This is a anteroposterior view. This is a normal size. And look at it when the patient is sleeping. The airway is obstructed, and it has become so narrow and thin, and it is only reduced to a few millimeters or maybe 1 or 2 millimeters. And here again, you can see that the tongue has really produced a bulge there, indentation there, and it is the airway space is narrowed. This again is a reconstructed view from MRI. In the wakefulness stage, see, this is the retropalatal space, and this is the retroglossal space. See, during sleep, the retropalatal has been reduced to a thin, narrow line. Well, the retroglossal has remained normal in this patient. That means that this patient has got a retropalatal obstruction, but no retroglossal obstruction. And what more information can we get from the MRI? It can tell you how fat is the neck. You know that obstructive sleep apnea is very much, the pathophysiology is very much related to altered metabolic syndrome and altered lipid metabolism. And there is a lot of fat deposition. And this fat deposition happens around the chin and the base of the tongue. So look at these two patients. This is a patient with a similar BMI. This is 34, 35. But this patient is an OSA patient with an AHA of 56, and he has got a very mild obstruction with AHA of only 8.6. Tongue volume in this patient is very much increased at 95 millimeters cube, and in this patient it is only 66.5 millimeter cube. And the fat percentage is 42% in this patient, whereas you can see the fat deposited here also, and it is only 24% in this patient. So OSA favors fat deposition, and that is one of the reasons, like it is like a byway relationship. So because of OSA itself, the fat deposition increases, and the fat deposition further increases the size of the palate and leads to further obstruction. This is a dynamic MRI that is it gives you a picture of the dynamic state of the airway. See, you can see this is the palate, this is the base of the tongue. See, the palate is coming and obstructing, and the tongue base is also coming and obstructing. This can be done in the awake state or in this under sedation, so that you get a more clearer picture as to what's happening during sleep. Now comes the most important investigation as far as ENT surgeons are concerned. We are into surgical correction of obstructive sleep apnea in indicated cases. That is drug-induced sleep endoscopy. We are trying to do an endoscopy when the patient is sleeping. You know, it is not an easy thing, easy procedure to do an endoscopy while the patient is sleeping. The patient will naturally wake up. So we are trying to mimic sleep as much as possible. So how do we mimic sleep? By drugs. And the ideal drug should have a short half-life, no effect on muscle tone, and no effect on respiratory drive. And the patient should be just sleeping. I don't know whether you can see this. Yeah, the BIS of this should be, BIS is the bispectral index. That shows the level of consciousness of the patient. If it should be kept between 60 and 70. This is the one which we use for doing the BIS, for evaluating the BIS. And if it is below 60, the patient will slip into unconsciousness. And if it is above 60, patient may be kept conscious but sleeping. So one of the drug with these qualities are the propofol and dexmedetomidine are the most popular drugs for this. Propofol we are give in a is an ideal drug because its the action is very fast and the effect of the medicine also wears off very fast. And the propofol, the dose is 0.5 to 1.5 milligram per kilogram to induce sleep and supplemented with IV boluses of 0.1 to 0.3 milligram per kilogram. But the disadvantage is that you shall remember, I said there should be no effect on muscle tone. Propofol produces some laxity of the genioglossus muscle. Then dexmedetomidine doesn't have that problem, and it should be given in 1.5 microgram per kilogram over 10 minutes, followed by a maintenance infusion rate of 1.5 microgram per kilogram. But the problem for dexmedetomidine disadvantage is that, as you all know, it takes some time for the preparation of the drug, and the effect also takes a little more time to wear off. So if you look at it, the patient is kept supine on the table, and the fiber optic scope, you can use a nasopharyngoscope or a laryngoscope for that matter. It is passed through the nose, and once you taking into account if there is any obstructions in the nasal cavity, then it comes to the nasopharynx, look for any adenoid which is there, any remnant of the adenoid. Sometimes in an adult you might come across remnants of the adenoid. Then you come down, you might see hypertrophied salpingopharyngeal folds obstructing the airway. Then you come and you will be able to see the palate. The palate, from here you will see, so that you can see if there is any retropalatal obstruction. Once you have evaluated this is the velum. So once you have crossed the velum, you come to the oropharynx. Oropharynx level, you have two things. One is the tonsil here, lateral pharyngeal walls. Then you have the base of the tongue. And you see if they are obstructing the airway. And once you have crossed that region, you still go a little more down. And here behind the hyoid bone, below that level, you will come across the epiglottis. You can assess whether it's a floppy epiglottis or whether it's obstructing the airway. And then you will be able to see the laryngeal inlet. So you have to continue until you can see the laryngeal inlet clearly. You don't have to enter into the laryngeal inlet, but you should be able to visualize that. This is a short video of that. The patient is lying down and we are passing the endoscope. At the same time, we will get the video of the monitor. We will be able to see the site and type of obstruction. Now, how to evaluate the drug-induced sleep endoscopy? There are two types of classification. One is the WOT and the other one is the NOHL classification. What is the difference is in the sites. What is velum, oropharynx, tongue, epiglottis. NOHL is nose, oropharynx, hypopharynx, larynx. So first we will do the site of obstruction. We will assess the site of obstruction. Then the degree of obstruction. In what classification we see whether it's a total obstruction or a partial obstruction. NOHL, we say whether it's according to the degree, whether it is a 25%, 50%, 75% or a total. And then the type of obstruction, whether it's an anteroposterior obstruction or a side-to-side obstruction or a concentric obstruction, whether it is a combined, both anteroposterior and side-to-side, you will have a concentric obstruction. Now let's look at some of the videos of the dice. See, this is an obstruction at the level of the oropharynx. See, here you can see, you will be seeing the soft palate. This is the salpingopharyngeal folds on either side, and this is the posterior pharyngeal wall. So now let's see. You are seeing from the, as soon as you cross the choana, you can see from there this. See, you can see the uvula is getting pushed up, and there is both an anteroposterior as well as side to side obstruction in this patient. Now the oropharynx. Oropharynx is below the, we have crossed below the level of the soft palate. This is the soft palate, you have crossed below that, and from there you are seeing below. See, this is the posterior pharyngeal wall, these are the tonsils, and you can see the tonsils projecting into the airway and obstructing the airway. This is again the oropharynx. It is the tongue base. This is the hypertrophied tongue base with a little bit of coating over the follicles. And this is the posterior pharyngeal wall. You can see almost 75% of the airway is obstructed. And let's look at the video. Now we are still at the velum. We have just crossed the velum and there is a total obstruction. We can't see any airway now, but when the patient is breathing heavily, we can, a little bit will open up. Yeah, see the base of the tongue. Bulky base of the tongue pushing hard against the posterior pharyngeal wall, leaving no airway at all. You can see a few air bubbles here that is coming up from the larynx. Now the hypopharynx, NOHL, the hypopharynx is also a one level of obstruction. Hypopharynx is the lateral walls of the hypopharynx that come and obstruct the airway. See, both sides, the lateral walls are coming and obstructing and squeezing the epiglottis from either side. See, it's completely obstructing. Now, lastly, the epiglottis. Epiglottis can have a standalone obstructing part, or it can be part of a multi-level obstruction. So, see, it's a long and leafy epiglottis getting opposed to the posterior pharyngeal wall when the patient is breathing. This is one patient who will not tolerate a CPAP. Patient with epiglottic level of obstruction usually cannot tolerate CPAP. And multi-level obstruction is quite common. In fact, it's much more than the single level obstruction in obstructive sleep apnea. So the patient can have a collapse at the velum at the same time at tongue base, or it can have a collapse of the hypopharynx and it can have a collapse of the epiglottis also. And or patient can have collapse of all 3 levels or 4 levels. So this is one patient who has got a collapse of the epiglottis as well as the hypopharyngeal walls. You can see that. See, the epipharyngeal walls are collapsing. Now the epiglottis also will collapse. See, the epipharyngeal walls are collapsing. So it can have any permutation or combination of these collapses. You can have a nasal obstruction, mind you. It can have a collapse of the velum. This is the velum. You can see the hypertrophied salpingopharyngeal folds. This is a collapsed velum. This is a collapsed tongue. You can see a collapsed, if you look carefully underneath the base of the tongue, you can see the edge of the epiglottis. The epiglottis is getting pushed down by a bulky base of tongue. So he has got a collapse of both the epiglottis as well as the tongue base. And this is a epiglottic collapse. So it can have any combination of this, and your treatment, your surgical treatment is very much dependent on the findings that you get on drug-induced sleep endoscopy. DICE actually gives you a roadmap for surgery as to what all you should do during the surgery. So these are the investigations that we generally do in adult patients. But in children, the OSA is, although it is similar pathology, it is different in certain ways. If you look at the history of the patients, the nocturnal symptoms are to a large extent similar. Like they will have snoring, mouth breathing, increased work of breathing, sometimes paradoxical breathing. They will have a restless sleep, tossing and turning, and sometimes the patient child can't sleep, sits and sleeps. Then they can have apneic episodes, and nocturnal enuresis is very common. But daytime symptoms are very, very non-specific in children, and it can manifest as hyperactivity, difficulty in concentration, learning difficulties, behavioral problems, excessive daytime somnolence. Sometimes you see mood variations. So when children may not come to us with these symptoms. So, but when the child comes to you with these, with the snoring and mouth breathing and not able to sleep because the airway is blocked, the mother says he's not able to get his breath. Then you ask about these histories also. So they all together point towards an obstructive sleep apnea in children. Clinical evaluation, of course, you see when you see a child with tonsils like this, you see the tonsils are so huge, grade 4 almost, and the soft palate is just resting on it. And maybe the child will be having a soft palate collapse also. Tonsils can be graded, as you all know, from grade 1 tonsil, which is in the tonsillar fossa, to a grade 4 tonsil, which is kissing tonsil, or which are meeting in the midline. So when a child like this comes, you ask about the other histories also, so that to know that whether his child has a mere hypertrophic tonsil or is he suffering from an obstructive sleep apnea. Then the endoscopic evaluation of the adenoids is also very important, because adenoid is another structure that obstructs the airway in children very often. See, it effectively closes off the postnasal space. See, endoscopic adenoid, you can see that this is almost 2/3 of the airway is gone. This is a total airway is gone. This is maybe half the airway is gone. And you can see some cases. Sometimes they might be having infected adenoids, infected tonsils, but at the same time, they might be having an obstructive sleep apnea as well. So obstructive sleep apnea actually has become an indication for tonsillectomy, adenotonsillectomy in children, just because of the size of the tonsil and the adenoids. So when you are assessing children, just because they don't have sore throat, don't think that they don't need any treatment. So endoscopic grading of the adenoids is like this. Grade 1 is adenoid tissue filling 1/3 of the vertical portion of the choana. Grade 2 is adenoid tissue filling 1/3 to 2/3 of the choana. Grade 3 is adenoid tissue filling 2/3 to nearly complete choana. Grade 4 is complete choanal obstruction. So according to that, we have got different methods of dealing with adenoids now. So these children need surgical treatment and they have to be evaluated accordingly. So what are the investigations that we have? As we all do generally, the X-ray soft tissue in a lateral view. See, this is a complete obstruction of the posterior choana. Huge adenoids. But in this patient, you see, this is not a complete obstruction. There is some airway is there. But look here, you have got a big tonsil here. That is obstructing the airway. The posterior airway space between the tonsil and the posterior pharyngeal wall is very less. So it's more than the adenoid, it's the tonsil that is obstructing, along with the soft palate. This the one which I showed you, like that, the soft palate is resting on the tonsil and together they completely obstruct the airway. Sometimes it might even be touching the epiglottis. What are the other diagnostic tests that we can do in children? We can ask the parents to do videotaping or audio taping of the snoring and the sleep of the child. We can very well recognize the ethnic events if you look at them. Then pulse oximetry, overnight pulse oximetry can be done. And there is NAP polysomnography is there now, because the total complete polysomnography is difficult to do in children because it involves sleeping in the hospital and many hours, 4 to 6 hours, or maybe whole night evaluation. The child may not cooperate with that. So we have got NAP polysomnography, where polysomnography is done, but it's only for 1 or 2 hours. And the evaluation of the grading of the OSA is also different in children. Children should not have any apneic episodes. So the normal is up to 1. Anybody having more than 1 is abnormal, is abnormal breathing. Is 1 to 4.9 is considered mild OSA. 5 to 9.9 is considered moderate OSA, and more than 10 is considered severe OSA. So summing up, what I was trying to say is that clinical suspicion of sleep disorders is very important if we are to diagnose obstructive sleep apnea. When the patient comes to you, patient comes with a complaining of a dryness in the throat, a feeling of obstruction in the throat, not able to sleep properly, tossing and turning because something is blocking my throat when I try to sleep. You think about the possibility of obstruction of the airway. Clinical evaluation is very, very important, and the clinical parameters, all that we have described, should be used, and comorbidities needs to be taken into account, especially when we think about the treatment of these patients. And diagnosis of OSA, the gold standard is, of course, polysomnography. Although in children, we can do pulse oximetry also, and we can diagnose and videotaping with the pulse oximetry with the symptoms and other radiological evidence, we can diagnose obstructive sleep apnea. Confirm the sites and pattern of obstruction by drug-induced sleep endoscopy. Choose the correct modality of treatment depending on the patient's comorbidities, condition of the patient, severity of the OSA, and drug-induced sleep endoscopy findings. Thank you.
Thank you very much, Dr. Susan. Trainees, you may type your questions, comments in the chat box. So Dr. Susan, you may stop sharing the screen and pick up the relevant questions from the chat box and answer.
Can you show the first few slides before investigation? You want me to go back to
move to the next question.
Good evening, ma'am. Nice. Can you please explain Mallampati scale again? Mallampati scale is you ask the patient to open the mouth and put the tongue out. If you can see the posterior pharyngeal wall, the whole of the tonsil, whole of the soft palate, and the uvula, then it is Mallampati 1. That is normal. If you can see only the upper part of the tonsil and the uvula, not the whole uvula, but the soft palate, then it is Mallampati 2. If you can't see the tonsil at all, you can't see the uvula, you can see only the soft palate, then it is Mallampati 3. If you can see only the hard palate, that is Mallampati 4. Is that clear? Preliminary investigations, CBC, hemoglobin lipid profile. Yes, they are also important, but we have confined ourselves to the special investigations that we do in an obstructive sleep apnea case. But many of these patients have metabolic syndrome and coexisting diseases. So it's a good thing to do all these tests. CBC, of course, doesn't give you that much of information, but you can do the lipid profile, you can do the hemoglobin A1C. Many of them are pre-diabetic or already diabetic. You can do a ECG or an echo. So the complete evaluation of this is a multi-system disorder, and the effect is on the multi-systems. So it's good to have a complete evaluation of this patient. When to do post-operative PST, when to do the post-operative PST. Post-operative PST can be done 6 months after the surgery. For DICE, we need to keep the patient. Yes, of course, we are giving anesthetic agents. We have to keep the patient NPO. You have to take all the precautions that you take for an procedure under anesthesia for sleep endoscopy also. And it can be done in an outpatient setup also, but it's better to do in a room which is closer to the OT or within the OT complex itself. For DICE, we need to keep the patient, and yes, we have to. 6 hours. Can we grade adenoids based on X-ray lateral? Yes, we can do that. Any drugs other than propofol or dexmedetomidine used for DICE? People have used several of the sedating drugs have been used, but the problem with many of the drugs is that they have got central depression. So this is a patient who already has an obstructed airway and his breathing is not normal. So he has to put a lot of effort to breathe. So we don't want the central drive to be taken away. So that is why we want drugs which will not affect the central drive for respiration. So that's why we are not using other drugs. Any drugs other than propofol or dexmedetomidine used for anesthesia during DICE. We don't use any other drug because these are relatively safe medicines. Also mixed pattern of hypopnea. They can have both an obstructive element as well as a central element, because ultimately the breathing is controlled from the brain. So these people have an obstructed element, but their breathing pattern is controlled by the brain, and that is not normal. So some of them have a mixed pattern. But in my experience, we have seen that very often we are able to treat them if the central component is not more than the obstructive component. If we treat them as obstructive sleep apnea, they respond very well. How WatchPat helps in diagnosis? WatchPat is quite good in the diagnosis of obstructive sleep apnea, and it is not a must that we should always go for the level 1 or the hospital-based polysomnography. But in a patient who has got any of the comorbidities or any complication coming it has happened out of obstructive sleep apnea should have an hospital-based evaluation. How can we measure? We can measure the posterior airway space by doing the cephalogram. Like you can do an X-ray skull lateral view, or you can do an MRI and take the lateral sagittal cuts, and you can measure the posterior airway space, both at the level of the soft palate and at the level of the mandible or the epiglottis. Any more questions? Epworth sleepiness scale can be scored by the patient himself. If the patient is, you have to evaluate the patient, and if the patient can fill it himself. Very often we have made the patient themselves fill the Epworth sleepiness forms, score forms, or you can do it yourself. All these 8 situations you have to present to the patient. You have to ask the patient, ask them whether he feels sleepy during that situation. So by then we can score it very easily. You can score that. CPAP trial, we will be dealing with the treatment next session. We will be dealing with the treatment in the next session. So I don't want to go into the treatment part. Midazolam, as I said, no, midazolam is good, but its effect is very short, and sometimes the patient goes into respiratory depression. That's why we don't use midazolam. It's better to do polysomnography because you get an idea as to clinical evaluation. You will know that the patient is most probably having a obstructive sleep apnea. But when you put a patient under anesthesia and do a procedure, or you are using a drug which can produce some anesthetic agent which you are using, it's better to you make sure that this patient is having obstructive sleep apnea before that, and you have to make sure that this patient is not a good candidate for CPAP. Then only you go for surgery. Only if you are planning a surgery, you need DICE. Otherwise, you don't need DICE. Indication for DICE is whenever you are planning for surgery, or when a patient is non-compliant to CPAP. And if the patient is non-compliant to CPAP, that means there can be a collapsing epiglottis. That is maybe the reason why the patient is not compliant. Yes, the room should be silent. It should be a dark, silent room when you are doing a DICE. OSA and central. I don't understand. Central what? SA means what? No, it cannot be. If you are meaning central apnea, central causes for sleep disorders, from the history alone, we can't differentiate them. We have to do a sleep study to differentiate them.
So excellent presentation, Dr. Susan. We have covered almost all the questions. Thank you very much for the presentation, and thank you very much, trainees, for joining.
Thank you.